stay here in this room. And in this room, I am very pleased to start with introductions with Carrie Caulfield, who is our moderator and the facilitator for this particular breakout session. She is working at the Elizabeth Boggs Center at Rutgers University. She is one of the collaborating research entities with the AIRP project. Carrie, we're really happy to have you here today.
Thanks, Dawn, and everyone. It's a pleasure to be here and to, oh, there we go. Sorry, I had to rejoin. Okay, so it's a true pleasure to be here, and I'm really looking forward to hearing from the three presenters who are going to share their work with us and lead us in some conversation about their projects. And so without further ado, I will go ahead and introduce our first presenter, Asal Bastani, who's going to share her presentation, The Benefits of Telehealth Primary Care Services for Patients with Neurodevelopmental and Intellectual Disabilities during COVID-19.
Hi, everyone. Can you hear and see me?
We can.
Okay, great. I had to rejoin when it asked you to join as a panelist. Okay. So thank you so much for the introduction. We could go ahead and go to the first slide. Okay, so no, that was right. Yeah. So when I first thought about this research project, it kind of came about because the pandemic really created an inaccessibility of healthcare. A lot of research was being done on emergency care, not so much primary care services. So I kind of wanted to do this project to fill in that gap. And especially there is a lot of research on patients who identified as neurodivergent having, higher mortality rates for COVID, but there wasn't a lot of research being done on how primary care services were affected. If you go ahead and go to the next slide. So here I just have a couple of quotes that I found pretty shocking. When I was doing my literature review, I'll just go ahead and read the last one. So those with intellectual disabilities face a mortality rate of 2.75 times when compared to the general population following a COVID-19 diagnosis. So there was a huge discrepancy in the care that was being given to neurodivergent patients, and I kind of wanted to see if primary care might have any part of it, because again, all the literature I can find just associated this with emergency healthcare. You could go ahead and go to the next slide. So the way I structured this study was 6 semi-structured interviews with clinicians and primary care providers. The interviewees had to have a lot of contact with neurodivergent patients regularly. Some limitations of this was that a lot of the interviewees were located primarily in the LA area, so I was limited in geographical coverage. We could go ahead and go to the next slide. Okay, so some of the questions that I asked really focus on clinician perspectives of patient experiences of telehealth, so kind of seeing how the transition to using a majority telehealth for appointments and services was handled in certain settings, and understanding the challenges faced by clinicians when they had to undergo this transition. Could go ahead and go to the next slide. Some notable themes that I was able to get from from the interviews is that physicians reported their patients feeling generally more comfortable with telehealth as opposed to in-person healthcare. And a lot of patients seem to be really satisfied with telehealth because of how convenient it was. They didn't have to commute, which is a big issue in LA. So yeah, so the outcome was more positive than I might have anticipated at first going into this, but it's good to know. Next slide. So even though there was a positive review from physicians and clinicians and patients for telehealth, there was also a need for in-person healthcare services as well. So telehealth doesn't completely replace in-person healthcare services. That was really underscored in a lot of interviews that I conducted. And then some actually claim that telehealth allows the patient to provide more information than they usually would in a regular office appointment, because maybe they feel more comfortable in their home. They feel that they have a bit more privacy, etc. Go ahead and go to the next slide. And here is just some interesting quotes I derived from the interviews. So I'll just go ahead and read the last one. In the clinic, patients will start to talk about things they didn't necessarily plan to talk about and really gain a lot of information that way. So here we kind of see the opposite. Some people had different perspectives. Some people thought that patients shared more information in the office compared to telehealth appointments. So really just depends on the field and who you're talking to. Okay, go ahead and go to the next slide. So some future applications. So continued implementation of telehealth services was big. A lot of services are being still offered via telehealth. And there is some work to be done, and this study could kind of contribute to guidance to widen and sustain accessibility to necessary services, and while maintaining flexibility for both clinicians and patients in accordance to telehealth or in-person services. Could go ahead and go to the next slide. And that's my presentation. I wanted to open up the floor for any questions before I introduce my own questions I've prepared as well.
Sorry, I don't know if can you hear me?
Oh yeah.
Okay. When you talked about the mortality rate for the folks who had neurodevelopmental disorders and the care, did you compare that to pre-pandemic? So to see if there was an increase because of the pandemic?
So that study just compared the mortality rates of patients with intellectual disabilities who had a COVID diagnosis and died after it or because of it, compared to the general population who also got a COVID diagnosis. So it's comparing those two mortality rates. It wasn't comparing pre-pandemic, which I think would be interesting to do.
Yeah, I was wondering, yeah, because it was only talking about people with COVID. Yeah, it would be interesting to know without including the pandemic, their regular standard of care. Yeah, thank you.
Is there a question from Cheryl?
Okay. Any other questions before I move on? For the last couple of minutes to my own questions. Go ahead and go to the next slide. So here are some questions that I pre-wrote for this presentation. So were there any other themes that you were curious about that I didn't cover, wanted me to maybe go more in depth? If anyone has any responses to any of the questions on the screen, feel free to raise your hand and answer, put it in the chat.
Sorry.
Does someone have a question? Okay,
There it
another-
goes. Now you can.
Yeah. Okay.
I know from personal experience, my daughter, who's on the autism spectrum, during the pandemic, tried to get telehealth
Mhm.
for her primary care, and she could only get mental health through the telehealth, but the primary didn't quite, I guess, embrace that. She's on the East Coast, so they didn't kind of embrace that. I'm kind of curious if there were, I know you said your study was just limited to Los Angeles. It would be interesting to me to know if there are regional differences in the approaches and care, because I know for her, she has, co-occurring mental health issues. And so she really felt more comfortable with telehealth. I mean, she wished all her healthcare was telehealth. So that would be interesting to me to know if there are regional distinctions, and maybe, expand on who's more likely to embrace it going forward.
Definitely. Thank you so much. That's a great comment. I think I'm at time, so I don't want to go over, but thank you so much for having me. This was amazing.
Thank you, Asal, for a very interesting presentation. And I will add just one other thought in response to some of the questions that you had posted there. In some preliminary work that was done where I am in New Jersey, we noticed some differences in the way that patients from different culture or ethnic backgrounds felt about the acceptability of telemedicine. So that may be a future direction to explore as you work to get input from patients directly. So thank you for your presentation. And now I will introduce our second presenter, Holly Long, who is going to share her presentation, Special Education Law and Interprofessional Collaboration, Viewing Education Through an Occupational Lens. So Holly, welcome.
Hello, everyone. My name is Holly, and I'm a blonde-haired woman in a red top. I am a recent graduate of Towson University with my doctorate in occupational therapy, during which time I completed my capstone project in research at Project HEAL at Kennedy Krieger Institute as a Maryland Center for Developmental Disabilities trainee. And the title and focus of my research is Special Education Law and Interprofessional Collaboration, Viewing Education Through an Occupational Lens. You can change this slide. Thank you. During my presentation, I will briefly discuss the background of my project, as well as the needs assessment, focus, research design, and results and implications, which will be followed by time for questions. Next slide, please. I wanted to start off the presentation with this great quote emphasizing the importance and value of education. As stated by Kofi Annan, the former Secretary General of the United Nations, education is a human right with immense power to transform. On its foundation rest the cornerstones of freedom, democracy, and sustainable human development. Next slide, please. Education is a human right, and in the United States, this right to a free, appropriate public education is protected under the Individuals with Disabilities Education Act, also known as IDEA. Yet, despite IDEA's protections, many students lack the services they need to progress at school. Next slide, please. This problem is one I chose to investigate at my capstone site, Project HEAL, a medical legal partnership and community-based program of the Maryland Center for Developmental Disabilities that seeks to provide special education, legal, and advocacy services to students with disabilities who are patients of Kennedy Krieger Institute. Here, the initial needs assessment highlighted that issues with service provision often arise among service providers and school-based team members in the special education process. Next slide, please. So my research focus was to identify these issues as they arise in interprofessional communication and collaboration among members of the Individualized Education Program, or IEP team. The IEP is a legal document developed for each public school student who requires special education and is a team-based agreement among the family, educators, and related service providers, such as occupational or physical therapists. Next slide, please. After conducting an initial needs assessment, I recruited families, educators, attorneys, and other members of the IEP team, including occupational and physical therapists, a speech language pathologist, a school psychologist, and a teacher to the vision and hearing impaired, to participate in individual and focus group interviews. After meeting with a total of 22 participants, I used descriptive coding and thematic analysis to interpret the data I gleaned from interviews. Next slide, please. So my data analysis resulted in 5 final themes. First, that parental involvement and advocacy are key to student success. That invested educators are a great strength in the special education process. That team members and related professionals often lack a clear understanding of roles and the special education process in general. That communication and collaboration are integral to the process. And that system-based issues limit special education service provision and follow-through. Next slide, please. I wanted to include a few of the most salient quotations that identified some of the limitations in the special education process, perhaps particularly a result of the COVID-19 pandemic due to the timeline of the study from January 2021 through May of 2022. Regarding team member knowledge and communication and collaboration, one teacher felt that team members are flying out of the seat of our pants, while a mother noted that the one hand doesn't know what the other hand is doing when she described the dynamics of her child's IEP team. For another team member, system-based issues such as funding and resource limitations meant that the task, in this case of completely fulfilling every student's IEP, was oftentimes impossible. When students' IEPs are not fulfilled, their academic experience often suffers as a result, with one mother of a student with autism stating that her son wanted to pull the fire alarm to get expelled so he wouldn't have to go to school anymore. Of note, however, this mother was very involved in her son's team, which eventually led to a very successful outcome to his academic career. This leads me to a final quote from a teacher who pointed out that the biggest determinant of success for a child is how engaged your parents are. Next slide, please. Despite limitations, including the impacts of the COVID-19 pandemic and representativeness of the sample population, which stemmed from several counties in the state of Maryland, the findings of the study resulted in a larger needs assessment of the special education process, but highlighted invested parents and professionals along with consistent communication and collaboration as the greatest strengths in service provision. Of note, students living in poverty or from culturally and linguistically diverse families with limited English proficiency often came up as having greater needs and issues in the special education process. As members of the healthcare team, it is our duty to remove barriers to function. By better understanding the needs of the special education team, we may advocate and act to prevent these issues from the start, to remove barriers and expand access to function for each and every student. And next slide, please. I listed a few suggested questions for feedback. First, did you find any of the results particularly surprising or significant? Do you have any suggestions for improving future related research and/or advocacy efforts? How can we promote educational equity despite the diverse needs that exist? And please feel free to ask any additional questions you may have as well.
Cheryl, I see your hand. Go ahead.
I'm just wondering, do you think we're going to get to a place where the team consists of an advocate?
That it seems, I mean, at least from my research, it depends on a lot of times the parents' willingness and perception of having an advocate. I know, some of the families I interviewed felt like it was like a hurdle to get an advocate, that there was a lot to go through to actually have one on the team. And so they actually opted not to, even in the cases where it may have been in their best interest. So that's something where perhaps family education on what that involves and the benefits of it might help with that. But then in some cases you have families who really go out of their way to get an advocate. And so it seems to be something that falls back on education and kind of the family's willingness and perception of what that involves.
Yeah, because I was thinking that might help with bridging the problems with the diversity and cultural differences. If you had an advocate for those families that really don't understand the process, because all of us who are on the team as educators or service providers, oftentimes we work for an organization, so we can't really, we're stuck in the middle where we can't really be an advocate.
Right. Yeah, and that's a great point, especially for those families who might have communication related barriers.
Okay, Holly, thank you so much. I don't see any other questions in the chat at this time. I encourage folks to continue to consider the questions of all of our presenters and to reach out to them with additional feedback via email as well. And I will ask all of the presenters if they're comfortable sharing their contact information in the chat to do so. And so now it's my pleasure to introduce our third and final presenter for this breakout room. I would like to welcome Lisa Schulman, and she's going to share her presentation, Toe Walking in Young Children with Autism, Prevalence and Clinical Associations. So hi, Lisa. Glad to have you here, and I'll turn it over to you.
Thank you, Carrie. I am a white female with brown straight hair, bangs, glasses, and a black and blue shirt. And I am presenting today on a topic that got a great lead in from the ARFID lecture. And I'll explain why I think that is. We're talking about toe walking in young children with autism, prevalence and clinical associations. Next slide. I'm presenting on behalf of my long-term colleagues, Dr. Rosa Sejo and Dr. Maria Valicenti McDermott, and myself. Next slide. Toe walking is a motor finding associated with autism spectrum disorder. Toe walking is seen in about 5% of the general population of young children versus 20 to 63% in the literature of children with autism. So clinically, it is a common red flag for autism spectrum disorder among the young children at our center and elsewhere. Few studies have looked at findings associated with autism spectrum disorder in children who toe walk versus those who do not. Next slide, please. So the objectives of the study were to assess prevalence rate of toe walking in a clinical population of young children receiving an initial ASD diagnosis at a large interdisciplinary inner city clinic, and to examine the association of toe walking with age of ASD diagnosis, clinical features, and autism severity in an ethnically diverse population. Next slide. So our setting is worth noting. It's the Bronx, New York, the poorest, most diverse, youngest urban population in the United States. 42% of households with children less than 18 years of age live below the poverty level. It's 55% Hispanic, 43% Black, 32% of the population is foreign born, and 56% speak a language other than English at home. The US Census considers the Bronx to be the most diverse area in the country. and it's the third most densely populated county in the United States. Next slide. The design and methods for the study included a review of charts of children with an early diagnosis of autism, an initial diagnosis, between 2003 and 2012. The data collected from the chart review included demographic and clinical characteristics. Toe walking was assessed by clinical observation during the course of a pediatric neurodevelopmental evaluation. Next slide. 512 children were identified as receiving an initial diagnosis of ASD during this period, and toe walking was observed in 30% of those children. And there were differences found between the children with ASD who toe walked and those who did not toe walk. The children who toe walked were diagnosed earlier, on average at 2-year, 9 months of age, versus those who did not toe walk at 3.5 years of age. P less than 0.001 significance. The latter group was diagnosed at 3.5. Also, toe walking was more likely to lead to an ASD diagnosis under 3 years of age. There were no differences in gender, country of maternal birth, bilingual household, insurance type, or race or ethnic groups. Next slide. The clinical results highlighted that children with toe walking had more sensory sensitivities in general, and those who toe walked had greater autism severity based on the childhood autism rating scale. Again, there was a significant difference in score with those who toe walked having an average score of 36, and those who did not toe walk 34, P 0.001. There were no differences in cognition, language regression, family history of autism, or the presence of seizures. Next slide. So our key takeaways were that in this ethnically diverse population that often does not step forward asking, is my child autistic? Children with autism spectrum disorder who engaged in toe walking were diagnosed earlier and demonstrated greater severity of social impairment. And our key takeaway that relates to the ARFID discussion is that in this population, toe walking may serve as a clearly observable sign that helps children find their way to an early diagnosis. Just as the ARFID diagnosis that we heard about in the keynote address sometimes led and was the beginning of a diagnostic journey for a family whose child had restricted eating. Next slide. The association of toe walking with greater autism symptom severity and sensory sensitivities may help identify a meaningful clinical subgroup of children with autism for further study from etiologic and treatment perspectives.